So just introducing the panel, this is a session on navigating challenges in robotic HPB surgery. And my name's Raj Lahiri. I'm one of the consultant HPB surgeons at the Royal Surrey in Guildford. I trained in Cambridge, London, Guildford and Melbourne. And introducing the co-chairs on the panel, we've got Ed, who's a consultant surgeon in Nottingham, who trained in Liverpool following his PhD in Birmingham. We've got Sulat, who is a consultant HPB and transplant surgeon in Birmingham, who aspires to setting up a robotic living donor programme in time. We've got Jamie, a consultant surgeon from Bristol, who is an interest in complex vascular resection and reconstruction and had a fellowship in Vancouver. And Jen, who's a consultant surgeon in Leicester, who previously had a PhD in mechanical engineering. And it's my pleasure to introduce my colleague, Angela Riga, who's one of the consultant surgeons and one of my former trainers in the Royal Surrey. Angela is also the lead for cancer services, and knowing that will perhaps highlight some of the benefits she's shown in us developing our HPB programme in Guildford. She trained in London, Dublin, and a travelling fellowship in Memorial Sloan Kettering, and is discussing unit-wide strategy for establishing a robot HPB programme.
Thank you very much for inviting me in the conference today. It's been it's a privilege to be here, especially with the expansion of robotics in the last few years. You obviously heard a lot about Guildford and our access to robots and how lucky we are. So I'll just tell you a little bit about how we got the program off the ground. We were lucky in the fact that we already had a well-established urology and gynae-onc robotic program. We are a smallish general hospital with 520 beds, but we do have a big cancer centre which is co-located, and we've got established tertiary cancer surgery for various specialties. So when we first set up to expand robotics into other specialties, we had 3 SIs. The business case was done at the time when I was a chief of service, actually, for diagnostics and clinical support services, to change the 2 SIs into XIs to allow other specialties to come on board. And then we also have a long tradition on minimally access training with the MATU that we have. So we also have quite one of the sort of pioneer centres for enhanced recovery. And as you can see, our enhanced recovery for livers is the length of stay is actually 4 days. So the hospital is quite used to getting people in and out quite quickly. Although on the other hand, it's more difficult to show the benefits of minimally invasive surgery when your open cases are going out so quickly. And as we said before, sometimes you have to look into other things. And again, we were on that trajectory of increasing minimal access options for HPB patients before we got on to robotics. When we started, we were a unit of 7 HPB surgeons. But we wanted to make sure that this was a collaborative approach and a team effort, and we didn't want anybody to be left out or have any animosity for that. So we had an HPB consultant meeting to see how we would actually get the pathway off the ground, how we would design it to meet the unit requirements. So we looked at how many surgeons we had, who wanted to train in robotics, what order we were going to do the training, what cases we're going to start with. And the general principles were to have equality of access in training, to have robotic cover for every robotic list. We have an operational meeting where we allocate patients to make sure that we utilize all our lists appropriately and our cancer patients are not disadvantaged. So actually we used that meeting to try and allocate appropriate cases for the robotic surgeons, depending on the level. And we made sure that we had 2 consultants operating for all difficult and first-time cases. And the final thing was we were absolutely adamant that this would not compromise our outcomes, and we're going to keep a close eye on that. So, as we said, 7 surgeons, 6 wanted to come on board. 1 was peri-retirement and felt that this was probably not the right phase in his life to actually embark on robotics, which I think is actually very fair. So with the way we selected is we said the first 2 consultants were the ones that the highest laparoscopic experience. The second pair was the next highest, and the final pair was the less experienced, but actually wanted to develop robotics. So the aim was to progress the first pair to level 2 cases at similar time to the second pair to allow for flexibility and better utilization of theatres and case access. But so with this in mind, all 4 surgeons were booked for the TR100 before the program started. We booked the proctoring for the second pair, so again, sort of simultaneously with the first pair. So the initial requirements were to make sure that you've done your sim and you had good scores. People went for case obs in the various in other centres. We did the TR100, Griffin Institute. And then we had 2 level 1 proctored lists per surgeon, per starting surgeon in quick succession. You can see there that so there was kind of, depending again on proctor availability, we wanted to make sure that we would have 2 or 3 lists kind of close together. And the patient side assistant was one of the second pair, so that increased the experience, the exposure on the robotic lists. So basically, the first pair did 12 cases in 4 days, and we made sure that they did 12 cases. In 1 case got cancelled, but got replaced with an emergency case to make up the numbers. So after 12 unproctored cases, the first pair progressed to level 2 cases, which were distal pancreatectomy and level 2 resection, actually slightly ahead of schedule. Because they had quite a significant laparoscopic experience. The second pair got proctored for the level 1 cases, again in a very similar way, high volume cases close together. And then for the level 2 cases for the second pair, because we've had already the first pair trained and we've got a dual console and we had double consultant operating, we actually could get the level 2 cases off the ground for the second pair that way. The level 3 progression, we took our time. I think we wanted to make sure that the experience was there before we moved to a level 3 case. So our first level 3 case was actually 12 months after the program started, and for liver, and 18 months was the first proctored robotic Whipples. And again, for robotic Whipples, which is obviously quite a challenging operation, requirements, in addition to case obs and wet lab, was also to using the LearnBot to practice HepJudge and PuncJudge anastomosis on the model and review the video recordings of the anastomosis. So, and that made a big difference to when the time came to actually do the anastomosis on real patients. Obviously, careful selection of patients, 1 robotic case per list and nothing else for the proctored lists. And we had 4 proctored lists in 3 months. Again, ideally, you want that a little bit closer. But as we said before, at the time, we only had 1 proctor in the UK. And Jao has been absolutely amazing at supporting us. But clearly, he couldn't be there all the time. So, and a double consultant operating with 1 surgeon doing the reconstruction and the other doing so 1 did dissection and the other the reconstruction. And the 3rd, 4th, and actually now 5th surgeon are currently proctored inside, proctored in-house for the level 3 cases. Challenges? Well, access is a big issue, as we've said before. Actually, it's not. Our existing robotic teams and other specialties were happy to offer up the robot for us to proctor, but it was difficult to get the regular access afterwards to continue to do the cases. The other thing that happened was that because we had 2 different platforms, we had 2 XIs and 1 SI, people who were using the SI before didn't want to continue using the SI because the XI was a superior machine. So actually there was issue with utilization of lists and access to the XI platform. obviously impact on regular operating, training requirements for the assistants who is assisting, and then proctor time. To try and counteract the issues with access, we had a robust approach of making sure that there was we had a robotic steering group, and we have a weekly robotic meeting where we actually look at all the robotic lists. So actually we flex the lists to accommodate more than one specialties. We move lists around even between ourselves to allow access to the robotic theatres for people who need it. We obviously demonstrated our patients benefited from HPB robotics we prepared the business case to get on to get another robot in. And actually, you'll see here, so we got the third XI, which replaced the old SI arriving in March 22, and the fourth XI in March 2024. You'll see here, it's always March. That's the end of the financial year. So actually, one of the things you need to remember, if you want to get something off the ground, make sure that you hit that target, have something ready to go when the capital is there to be spent. So, and you can see here on the robotic cases, so when we first started, we started with level 1 cases, which is the blue columns. So obviously level 2 cases for the first pair are being added. And then we have a dip down here. That was lack of access. And then the third XI comes in, and then the access is increasing. And again, here it just shows numbers, so the cumulative numbers of cases per surgeon. And then you can see actually most surgeons are roughly doing the same volumes, apart from the grey one, who actually tends to be, has a specific interest in robotics, and he's actually become the second UK proctor for HPB, whose team. And here you can just see that's the utilization, as we said before. So these are the 3 theatres. You can see here the SI fully utilized, the 2 XIs well utilized, and then we move on to having the 3 platforms, and then all 3 theatres are utilized. So actually, when you're trying to make a case to change technology, one of the things that it will push your business cases by showing how your theatres are well utilized for having the right equipment in the right place. So yes, there was a drop in the case volume during training, especially for level 2 or 3 cases. But in general, most people will return back to a mean average when they start doing level 2 cases on the robots. Although we distribute cases, as the experience increases, you have to distribute cases less and less, because obviously you can do more and more robotically. So important to look at the outcomes, and this is just looking at the first 90 cases that were done, which were obviously mainly level 1 and level 2. But even with this level 1 and level 2 cases, there was enough to show that even with the lower technical difficulty levels, you still have savings, despite the fact our length of stay for livers was actually so low. And we showed, for example, that we gained on overnight stays and on ITU bed stays. So again, that made the case to actually get another robot in. So current status at the Royal Surrey, we've got 8 HPB surgeons, 7 of them trained robotics, the 6th and 7th are currently were trained in-house. So by December, we've done over 600 cases. I think we're now kind of over 700, I think. And you can see kind of here is about 300 of them. So half of them were level 1s, but the others were a mix of level 2s and level 3s. And we have regular access to 10 lists a month, which are robotic. We do now join cases with other specialties like colorectal, gynae-onc, urology sometimes. So what went well? I think we kept it collaborative. That was really important. I think having the second consultant, the second pair to be patient side, that increased the experience. Having regular data monitoring that allowed the program to progress safely. Everybody being on board helped with case allocation, and being also having clarity on the pathway again stopped any squabbles. So what we'll do differently, I think, again, I mean, you've got to work with what you have. I think sorting out access is really important, sorting out assistance and training. Again, I think one of the things we've noticed is that our registrars, obviously the training, as we were training, the registrars that were coming through having less training exposure. So what we wanted to make sure is that they trained at least on robotics. So we made sure that they had their bedside assisting signed off when they started with us, that they had their access to a SIM, and then they could start doing some console cases. And then now we're looking into requirements for nurse surgical assistants, because then that allows your trainee to sit on the second console and actually be trained. So what are the specialists say? So obviously important to sort out the access, train the whole team, don't work in isolation, and make sure that you keep an eye on the safety. So in conclusion, I think follow a formalized pathway. Everybody knows what the pathway is. Lay the groundwork early, work as a team, but accept that people will work at different pace, monitor your outcomes, and actually get involved with clinical management and have your business case ready by the end of the financial year. And then last thing, as Jawan said, charity and patient story makes a big difference on fundraising and getting your equipment in. Thank you.